Hello, I'm Nina Melendez, and welcome to LinkedIn News Live, where the business conversation begins with you. Today, we're discussing healthcare. In this country, it's a $3.5 billion industry that is severely suffocating Americans everywhere. 1 in 5 currently have medical debt in collections, and it's not just detrimental to patients, but the cost of healthcare is burdening businesses across America as well. And if you pay taxes, it's burdening you too. How did we get here, and what are the solutions? Well, joining us now is Dr. Marty Makary. He is a professor at the Johns Hopkins School of Medicine and Bloomberg School of Public Health. He is the author of the New York Times best-selling book, The Price We Pay: What Broke American Healthcare and How to Fix It. He is a graduate of Harvard University and did his surgical residency at Georgetown. Doctor, welcome.
Good to be with you, Nina.
It's really great to have you. I have my book here. I've been reading it and have just been enlightened. I want to say that, the issue of the broken healthcare system is one that's been going on for years. What made you write this book now?
Well, I think people are getting fed up, Nina, and I think that for doctors and nurses, this is a wonderful profession. The medical profession is an amazing field, and it's being tarnished now. Our public trust is being eroded by some billing practices that are downright predatory. So I think we can address, this is a fixable problem, right? The problem of price gouging in healthcare, these are self-inflicted wounds that we can fix.
Some of the problems right now that you mentioned in the book, there are many. One of them, which I found really horrible, was the price gouging practice that happens not everywhere, but in many hospitals and medical centers around the country. Can you give us an example of an egregious yet widespread example of this?
Well, look, we found prices that were 11 times higher than what Medicare would pay for the same service. That is what the hospital would gladly accept from Medicare. And we're not saying every hospital should be paid Medicare rates, but we are saying that when you don't show prices, it opens the door for price gouging. And I think the point you just made is one of the key points, and that is it's not everywhere. There's a lot of good actors. We have a lot of good people in healthcare. As a matter of fact, most people I meet in healthcare at every level are good people working in a bad system. We've inherited this crazy game of jacking up prices for the purposes of offering secret and selective discounts to different health plans. And that's a game that we can address. I think if you think about when people shop for care, they're interested in the financial toxicity, in whether or not the care could set them back significantly or put them into bankruptcy. Half of America has basically lives paycheck to paycheck, has less than $500 of cash on hand. And I think we forget about that half of America, and we forget about them in healthcare sometimes. When you look up a hospital, you should be able to search that hospital on a search engine and not just see the name and address and phone number of a hospital, but the name, address, phone number, and average price markup and their billing quality score on a basic 5-scale billing system.
So this idea of price transparency, which is simple yet brilliant, because you're right. If I'm going to go for a procedure, like you go for a restaurant, you want to look at what you're going to pay for. I have a full screen of some of the results of your research that show that price transparency is actually a positive thing. There's a 50% of increase in patient volume back to the medical center that has price transparency, 30% increase in revenue, and overall increase in patient satisfaction. So if this is the case, Doctor, why don't more medical centers engage in price transparency?
Yeah, so you're right. Our research found that price transparency is not only profitable for institutions, but patients want it. And matter of fact, a Harvard study found that 88% of all Americans want greater price transparency in healthcare. I think the barrier, though, has been the legacy way of doing business in healthcare. And that legacy way has been to have secret and selective discounts that are negotiated with an army of staff. And by the way, all of that costs money, right? When you pay for something in healthcare, the price is built in of that massive negotiation and coming at a negotiated rate. And what we're saying is that can happen and continue to happen, but let's also show simple cash prices and let's let the market compete. The fundamental problem in healthcare is we have non-competitive markets. And when you see that, you can either say, let's regulate those prices, or you can say, let's unleash the power of competitive pricing.
You gave a wonderful example in your book about someone whose wife was going to give birth, and so he went around looking at the different hospitals trying to find how much it would cost, and he couldn't find it. They just were not upfront with the cost. Some hospitals or medical centers will say that they upcharge, right? The price gouging. They upcharge because they have to cover for charity care. What has your research shown about that? Is that factual?
Well, first of all, yeah, I was really amused and saddened by that story. It's somebody trying to figure out what the price was to deliver a baby. Because a lot of insurance now, it's getting so expensive. You're responsible for 10 or 20% of the total bill, even after your deductible. So people are appropriately asking about, look, how much is the price of this, assuming things go well? And the price to deliver a baby in New York today ranges from $4,000 to $71,000 for the same service. In Boston, it ranges from $6,000 to about $30,000 for the same service. This is the kind of stuff that's making a lot of people rich in healthcare, but at the expense of the everyday American worker.
Wait, so Dr. Marty, so that's like a difference of $28,000. So when you say it's the same service, you mean really it is the same service, it's the same type of, doctor with the same credentials and the same kind of hospital equipment that you would get? It's really one-to-one $28,000 difference in price.
Well, we have massive variation in pricing. We also have variation in quality, but the correlation is not there as people would think it might be. And I cite that probably one of the most enlightening studies ever done was looking at the price of simple heart bypass surgery and the quality of that procedure using the most mature registry in all of healthcare. And there was no correlation whatsoever. Our research team looked at charity care and price markups and found there was no correlation between those two. And the hospitals that sue patients more frequently when they can't afford their bill, which is a tragic practice that still lingers in the US, it does not correlate with charity care. We just released that in a national dashboard in partnership with Axios.
I actually want to talk about the suing of the patients because that was also another practice that I was completely floored by. Before we get into that, I want to say hi to some of the members who are joining us. Looks like from all over the world, Samia from France, Beverly from Denver, Vanessa from Dallas, and Willie from New York. And if you have any questions for Dr. Makary, please drop them into the comments, ask him anything. He is a professor at the Johns Hopkins School of Medicine and just wrote the book, The Price We Pay, which is a wonderful book. I recommend it. Speaking of suing patients, Doctor, I was floored by this idea, and part of, suing patients who can't pay, I should clarify. When you did your rounds to the different medical centers, you would talk to the surgeons or the doctors who had performed the procedure, and they were clueless that their patients who couldn't pay were being sued, and not just being sued, but their wages were being garnished, right? And then you'd go to the CEO of the medical center, and the CEO was kind of floored by this as well. So it seemed like nobody knew that this was happening. Can you sort of clarify, like, where did this start and how did this get going?
Yeah, so consultants and lawyers approached the billing offices at some hospitals and said, look, we'll shake people down for the amount that they owe you. And what they ended up doing was suing people in court to garnish their paycheck. And we revealed this practice in a study in the Journal of the American Medical Association, showing that in the state of Virginia, about a third of hospitals were engaging in this predatory practice. And these were Walmart workers, food service workers, postal workers, even custodians who work at the hospital. And so we exposed this practice, and our students, that people on my team said, look, social justice is a generational value among millennials. And my team is mostly millennials. And they said, look, we want to stop this. We want to shut this down. So we went around the country and argued in court on behalf of people who were sued, and we win 100% of the time, and we'll continue to do it, and we're shutting down the practice. And in the new paperback version of the book, I have an afterword that talks about how 80% of the lawsuits in the United States have stopped because of some of the advocacy work we've been able to do, partnering with media outlets and creating a grassroots movement. These are services, when we explain them to the doctors providing them, they're angry that this had been going on. They many times were not even aware. And the students have said, look, We want to bring more public accountability around this practice, and that's why it's going down.
What happens if someone can't pay usually? If, does the hospital absorb those costs?
They do. And so when somebody cannot pay, our philosophy is, look, if the patient is asking for a price and they are not given a price for a procedure that is shoppable, that's not emergent, then you don't have a right to shake down this patient in court, garnish their wages, or damage their credit score. If there's an agreed upon price for a shoppable service that is something elective and non-urgent, then sure, you can send it to collections, and that will affect their credit score like any other debt. But what we have right now in the United States is people coming in for care with good intentions to hospitals who have a legacy of being a safe haven for the sick and injured. And then the hospitals gouging them on the prices and engaging in predatory billing. And we're saying, look, that violates the great spirit of the medical profession.
So hospitals will inflate the bills to generate more revenue. And then in turn, insurers will haggle for higher discounts to meet that. How do you stop that cycle for bigger and bigger discounts and then inflating the prices and inflating the prices?
Yeah, it's a crazy game, right? And again, we have good people in healthcare. This is a game we inherited, not a game we designed. Imagine in the airline industry, if you couldn't see the price of a flight, and instead the airline said, we'll give you the price afterwards. We have a secret negotiated discount based on your employer. We can't tell you the price. We can't tell you what you're responsible for. We'd say, look, this is a system where the lack of transparency will invite price gouging. And that's what we have in healthcare. So right now we have a massive movement in the United States, a regulatory effort now that's going to require hospitals to show prices of common shoppable services. Many hospitals have started complying with the rule. Some have said, we're not going to comply. We'll just pay the fine. We need public accountability around those practices. There's also a bunch of online platforms now where people can shop for care, like Sesame Care, which is one platform I'm involved in.
A lot of folks who responded to this post on LinkedIn, advertising for the show, said a lot of the comments surrounded health insurers. I want to bring up one actually from Thomas Henderson. He said, as a retired ophthalmologist, I often said to my patients that I thought medicine was a profession that was unfortunately also a business. What caused me to leave medicine and retire was a constant battle with insurance who wanted to substitute their best financial judgment for what I felt was my best medical judgment. Doctor, do you have any comment on that?
Look, people have a right to be angry right now. And I think what's driving some of the physician burnout, which is now at record high levels, is not the hard work. We're ready to work hard. We want to help people and take care of them. It's the loss of autonomy. And I think that's one example of it.
And I actually have another question from Daniel Brown, and he brings up another point in regards to health insurers. If we can bring up that quote, he says, U.S. healthcare has been broken for a while. The fact that health insurance is tied to employment traps people in jobs and prevents them from looking for work elsewhere. And his last sentence of it needs to be separated from employment is the one that I really think of. If you don't have a job, then you don't have health insurance. And it's almost, it doesn't make any sense. So what are your thoughts about separating health insurance from employment, and is that really feasible?
Yeah, look, a lot of people say that's the original sin of the American healthcare system. Nobody should worry about their insurance coverage when they switch jobs. Nobody should be afraid to switch jobs because of fear of losing some benefits. And yet that's the system we have. On the flip side, one of the most exciting areas in healthcare right now is the innovation by employers to redesign care on a small scale. And so we've got employers in the United States who have essentially fixed healthcare on a small scale within their population.
There's the other part that you bring up in this book, which was the over-testing and treating of illnesses. And you called it a quote-unquote epidemic of too much medical care. My question is this the result of being overcautious because we're such a litigious society? Did you find maybe in your research that doctors who are more likely to over-medicate or over-treat had been previously sued for malpractice or anything like that?
Well, we did a survey of physicians and asked them the reasons, and that was one of the reasons, but not the dominant reason as some people think. It's the culture of medicine, and some of it is driven by the perverse incentives in healthcare where we reward quantity over quality. Matter of fact, sometimes we don't even measure quality. It's just simply the more you do, the more you get paid. And so we've created this system, again, where good people sometimes within the culture of medicine do too much. And a lot of it's with good intentions. And I was very honest about that in the book with my own story, prescribing opioids. I prescribed too many opioids to people who I never should have prescribed opioids to, with good intentions, arguably, and bad science. But this is the culture of medicine. A doubling in the number of prescription medications in the last 10 years. Disease did not double in the last 10 years. We have a crisis of appropriateness. And it means we've got to treat more diabetes with cooking classes than just throwing insulin at people. We've got to treat more back pain with ice and physical therapy instead of just surgery and opioids. And we've got to treat high blood pressure by talking about the underlying lifestyle and stressors that cause high blood pressure.
I mean, something that you mentioned in your book about the opioid prescriptions, that the issue that you had was that you felt like you just didn't know, that you were told, to give your patient a handful of opioids and they would need that for recovery. Is maybe also part of the solution just re-educating or reinforming the doctors?
There's a lot of dogma in medicine. People think that all the decisions are based on evidence and studies. About 60% of all decisions are just purely discretionary and there's no evidence. And so we have a lot of dogma out there. And sometimes, to be honest with you, in the short 10-minute visits where people are demanding an antibiotic, there's an incentive for a physician to simply prescribe that instead of having the longer conversation. Same is true of mental health disorders and many problems. Imagine if we put research funding into environmental exposures that caused cancer, not just the chemotherapy to treat it. We need a more proactive system and less of a reactionary system.
But proactive, which doesn't make as much money.
That's right. Look,
preventative care is not as lucrative.
That's right. And, prevention is one word, but it doesn't even really capture what many of us are talking about. We're talking about the entire redesign of healthcare, starting from scratch, redesigning it from the standpoint as if you were a patient. And let's talk about food as medicine and the inflammatory state, which really is one of the best indicators of your overall state of health.
Yeah, I have a question here in the stream from Caroline. She asks, are there any silver linings from the pandemic in terms of shedding light on the worst parts of our healthcare system that will now be forced to be repaired?
Yeah, there's a lot. And so, look, one of them is that we've realized you don't need to come into the doctor's office to sit, navigate the parking garage. And, we've now recognized that we can do a lot virtually, and we can do a lot of monitoring virtually. We've also seen a total implosion of the cost of healthcare to the point where people are saying, you know what, we're going to go direct. We're going to do direct contracting with hospitals as a health plan or employer. We're going to have direct primary care, work directly with our employees at a site, and we're going to have a free market for medical services like you see now with some of these online platforms like MD Save and Sesame Care, the project I'm involved in.
So when you were doing the tour of the United States and you were talking to the CEOs of medical centers and even the surgeons, it seemed like there was a lot of cooperation and a lot of people who agreed that there needed to be a fix to this. Did you have the same reaction when you spoke to heads of insurance companies?
I did. I really was inspired, and I'm very optimistic about the future of medicine. And the business of medicine is getting streamlined because we've got entrepreneurs now seeing pain points and areas for opportunities. And we're recognizing now that there are businesses that can be designed around many of these pain points. For example, doctors have recognized in the emergency room that instead of simply waiting around for people to come to the emergency room, you can have a triage phone system where, if it makes sense, a doctor could go to the house. You're seeing a lot of home care now. You're seeing the use of nurses incorporated into more care outside the hospital. And all that is very valuable and a move forward. There's so much innovation going on right now in healthcare.
I want to ask you more about that. First, I want to say hi to some of the people who are joining us around the country. We've got Richard from Kentucky, Warren from Nevada, and Barbara from Virginia. Great to have you on the show. Any questions you have for Dr. Makary, please put them in the stream and we'll get those answered for you. So I also want to talk maybe a little bit of the policy side of this, Doctor. Have you noticed any willingness to sort of put new laws in place to prevent things like price gouging or suing of patients? Have you seen any sort of advancement on that front?
Yeah, there's a lot going on. There's so much good stuff happening right now. And a lot of this I incorporated in the new afterword of the paperback book. And for example, we saw an executive order signed under President Trump, and it received bipartisan support. And that is going to require hospitals to show cash prices. Under President Biden, we saw an affirmation of that executive order. And Javier Becerra, the new Secretary of Health and Human Services, has announced a new set of regulations to govern price transparency in the marketplace. At the same time, you're seeing the private sector move quickly to show those prices to people navigating their own care through apps and things with an easy user interface. And I think ultimately, when you go to get care, you're going to be able to see prices in the very near service for the vast majority of non-emergent services.
So I don't want to be a Debbie Downer, but let's look worst case scenario. If nothing changes, what do you think is going to happen with the industry in the next 5 to 10 years? And not just the industry, but people who participate in it, i.e. all of us. What is your crystal ball telling you?
You know, when enough people would ask for nutrition labels on food and demand it, and then reward the market by buying products that were honest about nutrition labeling, we saw a total transformation where we introduced competition around ingredients, despite the fears of the food industry to say that it would not be feasible and people wouldn't understand the labels. So too in healthcare, we need people on hospital boards to say, hey, we want to do the right thing and perform well on billing quality. We want to introduce measures of appropriateness, as we're doing now with our Global Appropriateness Measures Project. We're seeing insurance companies step up. You know, there is no one mindset of insurance companies, pharma, hospital leaders, doctors. It's based on the local region and the amount of competition in the region and the ethics and values of the individuals at any group. And so I would encourage people not to bring any prejudgments to their understanding of healthcare, and to help drive forward this new competition around pricing and quality, looking at appropriateness of care in a way that's healthy, I think, for everybody. I'm optimistic, and I think it's going to require, for good things to happen, patients to continue, consumers to be extremely involved in healthcare. That means asking for prices when they present for care.
You bring up a good point in your book, is that it's just so difficult to bring these topics up when you're, say, in an emergency room. And the first thing you're thinking about is your health and surviving, or, you know, what's wrong with you, versus thinking about your wallet. But yeah, I suppose there's power in number if we all called our local hospital and asked how much it would cost to deliver a baby, or...
Yeah, and quick tip, you should never sign any financial document in an emergency room. It actually violates if not the letter of the EMTALA law, the spirit of the law. So remember, never to sign your financial life away at a time when you present with an urgent condition.
Dr. Makary, I have one last question for you before we go. Ending on a high note, you spoke to several folks and organizations around the country who are doing it well, who are providing great care, great services, happy patients, affordable price. Can you give us an example of where this is happening and what they're doing right?
Well, I think it was most inspired by ChenMed, which was it's a series of clinics that was based in Florida originally and is now in over 20 states. And here's a series of clinics where they take care of seniors, anybody with a Medicare Advantage plan that allows them to participate. The senior doesn't pay anything to be a part of this clinic, but the clinic spends time with people. It encourages seniors to come in frequently, and it addresses the underlying causes that cause illness. They prescribe medications right from their clinic. And there's a clear mission of loving people in that clinic, so that if they have a problem, the goal is to figure out how can people get the best care and sometimes avoid unnecessary hospitalizations, rather than put people through the billing fee-for-service throughput model of modern medicine that, quite frankly, patients don't like, doctors don't like, and we have to start asking ourselves, if patients don't like it and doctors don't like it, why are we doing it?
Dr. Makary, thanks for joining us. I just want to give a very quick shout out to your book, but specifically your research team. As I was reading, I just found that you gave so much credit and kudos to your team that does a lot of the hard work along with you. So kudos to all of you and for helping change policy for the better.
Great. Thanks so much, Nina. Great to be with you.
Thanks for coming on. That was Marty Makary. He is a professor at Johns Hopkins University and author of the book, The Price We Pay. And thanks for everyone who joined us today in the conversation. You can continue the conversation here, or you can check out our news module. There are other stories to the right of your feed, or if you're on mobile, click into the search box. Thursday, my colleague Caroline Fairchild will be discussing the reopening of cities across the country, specifically taking a deep dive into the Big Apple and examine how it's supporting businesses and workers after a year of shutdowns. I'm Nina Melendez. Thanks so much for watching LinkedIn News Live.